Okay, like I said, good evening, everybody. Thank you for being here. We're very excited to keep going forward with our 50th anniversary speaker lecture series. I want to take a quick moment to actually advertise just the next couple months. We have a couple of great talks coming up as well to continue this series. And September 15th, we'll have Dr. Frank Domino from the University of Massachusetts give us a lecture on evidence-based medicine updates. That should be really great. I should mention that this is part of the CME event that's going on that week at the University of Washington, and you don't actually have to register for this. There will be details on how to view this coming later, and also make note it's at 8 o'clock in the morning, so a little different than our usual schedule. And then in October, most likely October 27th, but we're finalizing that. We'll have Dr. Ashwin Rao speaking to us, representing our sports medicine section in our department. I'm really looking forward to that. He's a personal mentor of mine, so that should be a lot of fun. Tonight's lecture is Dr. Jennifer DeVoe, and she is going to speak to us today on the recent National Academies report about primary care. What does it say and what can we do? And for Dr. DeVoe's for introduction, I'm going to pass this off to our own faculty, Amanda Widener.
Thanks, Dave. So it is my distinct pleasure to get to introduce Dr. Jen DeVoe. She is the chair of the Oregon Health and Science University's Department of Family Medicine, and that is another big department like ours. It includes nearly 200 faculty, 80 residents, and several of OHSU's primary care clinics, and she oversees all of that. She's a practicing family physician and also an internationally recognized health services researcher. She and her team were among some of the early pioneers leveraging EHR data for use in the health services research, health disparities research, and implementation science studies. She works with several teams at OHSU and OCHN, which is a large integrated network of primary care practices, who have a portfolio of research related to identifying and addressing social determinants of health in primary care settings and utilizing novel EHR-based tools to support this work. Dr. DeVoe also serves as the inaugural director of OHSU's new Center for Primary Care Research and Innovation, and she was recently awarded a P50 grant from the National Cancer Institute to develop a Bridge C2 Center, which is building research and implementation and dissemination to close gaps and achieve equity in cancer control center. Her incredible list of accomplishments includes being elected to the National Academy of Medicine in 2014, and she's served on several committees of the National Academy since that time, including most recently serving on the committee that just released the report we're going to hear about tonight, Implementing High Quality Primary Care, Rebuilding the Foundation of Healthcare. And I'm going to turn it over to Jen. Thanks so much for being here.
Thank you so much for having me. I will go ahead and pull up my slides. Hopefully you're seeing slides with two pictures on them. Excellent. Great. So thanks again for having me. Happy anniversary. We share the same anniversary. Here in the Pacific Northwest, we were pioneers in creating family medicine departments 50 years ago. So we're also celebrating along with you. So congrats. And certainly a very strong foundation that we've built that we're seeing the benefits of this year. Never been more proud to be a family physician, to be an academic family physician when I see all the amazing work that our teams are doing out in the world in response to the COVID pandemic and in response to a number of other initiatives related to social justice and climate justice as well. So without further ado, I will talk to you about the Academy's report. I do have some slides. Most of these were prepared when we launched the report in May of 2021. So I know there's a spectrum of people out there. Some of you have read the report word for word, so you know more about it than I do at this point, because 6 months ago when we were writing it, or a year and a half ago, seems like a long time, and I probably forgot some of the details. So please chime in if you have specifics or questions or thoughts. And then some of you have probably never heard of the report. So we'll try to kind of bridge that gap and settle on the middle a little bit with some basic information, and then go into some more depth based on where people have questions or interest in discussing it. So this first slide shows a couple of patients. And I think at the end of the day, in primary care and in all of healthcare, I think it's our patients that teach us the most. And much of what's in this report and the lessons learned have come from patients. There's also a lot of evidence and data that's been generated over several decades that's highlighted. But at the end of the day, I think it's patients that teach me many lessons. And I do like to go back to them. And I'm just gonna see if this is gonna let me advance the slides. Great. So here's a few of the lessons we've learned from patients, as well as the literature that was highlighted in the report. Primary care is a life-saving intervention. Primary care is the only part of the healthcare system that results in longer lives and more equity. Primary care is an essential, not optional, ingredient to a successful population health improvement strategy. It is possible to deliver old-fashioned, futuristic primary care. Primary care is weakening in the US when it is needed most, and we need to get primary care off life support. As any good academic, I've written about many of these stories and essays that are referenced here. The most recent one published this year, Getting Primary Care, a Life-Saving Intervention Off Life Support. Just wanted to highlight for you a few paragraphs from this paper. The patient who was pictured on the previous slide taught me some lessons, and this story was about my 18 years of caring for her as her primary care physician. The patient in this picture, who is also on the slide before, is my father, and I had the privilege of obviously knowing him and serving as a family member as well as a health professional in his life, and helped him make end-of-life decisions several years ago. So learned a lot in that process from him and the care he received, and how important it was to have primary care front and center in that experience. So the patient that taught me about how primary care is a life-saving intervention, we'll call her Valerie. She, just to summarize this article, again, if you want to read it, it's in Mayo Clinic Proceedings from this year, but she essentially was one of those incredibly healthy patients that I had gotten to know over the years. And because I knew her so well, when she came in for her annual wellness visit and flu shot, I noticed that she was showing some signs of what I thought was unstable angina. I sent her in for an urgent cardiology evaluation. She had a cath procedure and a stent at that time, which she believed saved her life. So when I went in to see her later that evening in our hospital, she thanked me for saving her life. And primary teams do not often get recognition for saving lives. Work performed by primary care teams is often invisible behind the scenes. Certainly in the last 2 years during the COVID-19 pandemic, primary teams are managing the vast majority of COVID-19 cases on the front lines, working in the shadows of intensive care units. We are the ones who get the calls when politicians and media outlets tell people to call your doctor. We provide the majority of outpatient healthcare visits in our country and are the healthcare system's front line of defense in responding to COVID-19. Not to mention that primary care interventions 20 or more years ago have helped patients successfully quit smoking and lose weight, save their lives when they got COVID. Healthier people are surviving COVID-19 at higher rates than those of the same age with worse health status. More recently, which I wasn't able to capture in this article, we are on the front lines delivering vaccinations to our communities and advocating for those to be equitably distributed in our country and around the world. So this also goes on to an experience I had early on in the pandemic when we were making that rapid shift to telemedicine and providing virtual visits and continuing to keep our doors open to patients who needed to see us. An insurance company executive shared with me that he was surprised to hear how hard my primary care team was working because he thought our practices were closed. Why would he think we were closed? As primary care teams flex to meet increased needs and work to create community-based management for the majority of COVID-19 infections, while also accelerating ongoing efforts to treat chronic disease, manage worsening mental illness, address social determinants of health, and creatively deliver preventive care safely. Primary care's presence was even less visible, given that a smaller percentage of the care we were providing at that time was billable. So at a time when our teams were working harder than ever, they were getting paid less and had become even more invisible. Primary care teams are doing everything possible to stay open, keep people safe, and to serve increasing demand with dwindling resources. When there is a mismatch between what society expects of a service and how we pay for the service, it can be taken for granted. It becomes an invisible service that everyone feels entitled to receive. But what happens when demand for non-billable primary care services suddenly skyrockets and billable services plummet? Or when the paid portions get out of balance with what the community needs, such that primary care teams are in an ethical dilemma about whether to provide the services they are paid, the services that are paid, or the services that are needed. These are sometimes mutually exclusive. So I concluded after this experience and in looking at what was going on around us that the COVID-19 pandemic is a stress test in how we pay for primary care and what we expect of primary care in multiple ways. It's showing the gross mismatch between a fee-for-service payment system and what we need primary care to do for our society right now and in the future. We as a country are failing the stress test. An integral part of our system, primary care, which is already on life support, is about to code. So I go on in here to give some recommendations. Some of them are similar to what our committee ultimately concluded should be recommended for the nation, but just wanted to really give that context, especially within the pandemic that we're currently experiencing on a day-to-day basis. So great timing to be in the midst of the experience that I was very fortunate to be on the committee to implement high quality primary care, rebuilding the foundation of our healthcare system. So this was the first report that the National Academies took on since the Institute of Medicine reported out on two landmark primary care reports in 1994 and 1996. So it's not like these happen every year or even every decade. This was an effort started several years ago. Family Medicine for America's Health, which was a strategic initiative that our 8 family medicine organizations launched, gosh, it feels like ages ago, was the impetus for really advocating that a new report needed to be, a new committee needed to be pulled together and a new report needed to be done. So this is several years of work in the making, lots of folks advocating for this, a significant amount of money raised by a collaboration of federal agencies, professional organizations, including our own in family medicine, as well as private foundations. Here's the list of committee members. I, again, was very fortunate to work alongside many of these people for the better part of a year and a half. We had 20 members. We worked for 18 months. There were a variety of professions, including physicians, nurses, dental professionals, pharmacists, physician assistants, a health center CEO, director of a community health worker program, economists, anthropologist, and sociologist. And many organizations, as I mentioned, sponsored the work. Our statement of task was to examine the current state of primary care in the United States and develop an implementation plan to build upon the recommendations from the 1996 IOM report, Primary Care, America's Health in a New Era, and to strengthen primary care services in the US, especially for underserved populations, and to inform primary care systems around the world. So this was a different statement of task. It was building on the report in 1996. We were able to review the significant amount of evidence supporting primary care and its impact on population health, but our task was not to report on this evidence. Our task was to develop an implementation plan. So you'll see in the next slides really what we recommended as far as an implementation plan for the nation. We had several meetings. Some of them were public information gathering sessions, some of them were committee meetings. We had commissioned papers from experts in the field looking at different aspects, a broad and ranging literature review. So if someone didn't consult you about what the committee should recommend, they likely reviewed papers that you've published and information that you've contributed to this large evidence base. The recommendations, as all recommendations from academies committees, were driven by consensus. We also had 16 experts peer review the report from a variety of disciplines. So lots of different perspectives and voices and expertise involved in producing the report. So as I mentioned earlier, you know, the context surrounding the study, primary care is the only part of the healthcare system that results in longer lives and more equity. Our primary care system is fragile and it's on life support in many places. But there are bright spots. There are guiding lights where local organizations, states, other places have successfully implemented high quality primary care. We also know that primary care provides comprehensive person-centered health care for individuals, families, and communities. We know that countries around the world with high quality primary care experience better health outcomes and greater health equity. Primary care in our nation is inaccessible to large portions of the population, and simultaneously the primary care workforce is shrinking. But these primary care workforce shrinkages and shortages are linked to reduced life expectancy. Primary care in the US is financially under-resourced, and one of the main concerns of the committee and recommendations was that primary care needs a unified voice within the federal government. There needs to be an organization that can help us oversee primary care, hold our nation accountable for building the primary care foundation and sustaining it. One of the examples and one of the experiences we were living during the time we were writing this report was that the COVID pandemic was revealing that primary care had no federal champion, which was likely why it was not part of the national epidemic plans and the response to the epidemic. It was not included explicitly in congressional relief bills. Primary care was not included initially as distributors of vaccines, despite being the largest platform for vaccination in our healthcare system, and a place where people turn for trusted health relationships. Another point here that was, I think, useful for the committee to report out on was that if you look here at visits to different sectors of the healthcare system, and that's in the yellow or gold bar, that there is a large percentage of people visiting primary care as well as specialty care in our healthcare system, and a very small percentage being hospitalized as inpatients. But yet when you look at where the expenditures lie, you can see the large mismatch between the small percentage being spent on primary care and the large number of people seeking care from primary care. 5% in the US as compared to an average of about 14% in many of our OECD nation counterparts. So one of the explicit tasks for our committee was to update the definition of primary care. So we started with the definition in 1996 and updated it. There's always wordsmithing that happens. There's certainly ways that this definition can be expanded upon or improved, but it was helpful to have a shared understanding of what we're talking about. So you can read this here, but I will go through a few of the differences and the updates that reflect key societal and sector shifts from 1996 to now. There was a shift in the definition away from services that were provided to integrated whole person health. The foundational sustained relationships at the core of primary care, the importance of communities as a focus, the need for primary care to be equitable, interprofessional care teams that deliver primary care, and the diversity of settings and modalities used to deliver primary care. So there were some updates. We had a very great definition to start with and updated it. So you see that here. I think another central element to the committee's deliberations and recommendations is that primary care is a common good. It has societal value, yet it's in a precarious state. So it's interesting because some people were raising points and there's continued debate about how do you get to a common good and shoring up a common good. And there are people that believe that market forces will get us there, that competition will help us improve quality, or that an individual has choice to utilize or not utilize primary care. But at the end of the day, we realize that we're not going to compete our way to a stronger role for primary care in our delivery system in its current structure of incentives and resource allocation. This requires public policy for oversight and monitoring, and we need strong advocacy, organized leadership, and public awareness. The same way that we're likely not going to obtain universal, high quality, and sustained elementary and secondary education if we compete our way there in a typical marketplace. So the implementation plan and the overview is that the value of primary care is indisputable. The evidence is clear. We know how to do it in small instances. We know how to do it in local areas in some states as well, but how do we get this to scale? This was, again, a fundamentally different charge from 1996, where the committee was tasked with laying out the evidence for primary care and recommending what was needed for a primary care system, we were really tasked with an implementation plan. Many of the recommendations from 1996, in fact, most of them were not implemented. So we were really taking another run at it to put together some basic recommendations for how do we implement the plan? How do we scale the lessons learned and the evidence that we know of what works? There's 3 elements: the system view targeting 3 levels, the macro, the meso, the micro. Second, accountability. This is for public and private actors. It's currently lacking. We have ideas, and I'll show you later on about creating a scorecard, not to score our primary care providers or put more work on their back, but to put that accountability within the federal government and within public and private entities to say, hey, you're accountable for shoring up the system, maintaining high quality, and these are ways in which that you need to be doing that and holding the nation accountable for it. There is a policy window right now. The population is concerned about the future of our US healthcare system. The COVID-19 pandemic has revealed a number of weaknesses in the system. So the 5 objectives, again, for achieving high quality primary care in the areas that we focused on, each of these is a chapter in the report. 1, payment to access. 3, workforce. 4, digital health. And again, all these are held together with the accountability. So the 5 objectives, and I'll just read them here and then go through them each with some specific actions. But 1 is related to payment, paying for primary care teams to care for people, not just doctors to deliver services. And that was somewhat of a shift from 1990s. Access, ensuring that high quality primary care is available to every individual and family in the community. 3, training our primary care teams where people live and work, so really shoring up the workforce. 4, digital health. This was a new one that wasn't included in 1996, but we need digital health information technology that serves our patients, families, and our interprofessional care teams. And again, 5th, the accountability aspect to ensure that it's high quality primary care is implemented in the United States. So paying for primary care, the first action is related to evaluating and disseminating payment based on the ability to promote the delivery of high quality primary care, not short-term cost savings. I think that there was a realization that over the last decade, there's been a promise that primary care and investments in primary care are going to save money and save the healthcare system and reduce the total cost of care without a recognition of the other elements of the quadruple aim. So yes, ideally, primary care will save money. It's probably not in the short term, it's likely in the long term. But then there was, I think, with that being the focus of a number of initiatives, people lost sight of population health as an outcome of access to primary care and health services, patient experience, as well as the well-being of the team, which are some of the other elements in the quadruple aim. The second action is that payers using fee-for-service models. And again, many payers still use that model. Many of us still practice primarily in that model. And I know we've been advocating for this for years, but we really do need to shift toward hybrid reimbursement models and making those models the default over time. And for risk-bearing contracts, payers should ensure that sufficient resources and incentives flow to primary care. So the primary care payment model should have 4 characteristics. It should support interprofessional integrated team-based care, should be risk adjusted for medical and social complexity. You know, a lot of work is happening in that regard, but certainly important. Allow for investment in practice transformation and infrastructure, and align incentives to measure and improve outcomes. And of note, the committee did recognize and acknowledge that there are a number of primary care teams that are already engaged in larger systems that are doing population-based risk-bearing contracts, but that those of us participating in ACOs or other such systems, that payers really needed to ensure that sufficient resources and incentives in the entire system are flowing to primary care. The third action step in this first objective, CMS should increase overall portion of healthcare spending for primary care by improving the Medicare fee schedule and restoring the RUC to an advisory nature. This really gets at, the American Medical Association has the Relative Value Scale Updated Committee, or colloquially known as the RUC. which has played an increasingly influential role in describing the resources required to provide various physician services. The committee felt like CMS needed to create and invest in an independent data collection, valuation tools, and expert panels to identify overpriced services while maintaining budget neutrality. So really getting professional organizations that have a vested interest in increasing the revenue that's flowing towards a particular specialty or subspecialty, sort of out of the rate setting business and more in an advisory role, and a more objective, unbiased organization advising CMS on what Medicare should pay for, which services are valued at what amount. And the fourth action here is states should facilitate multi-payer collaboration and increase a portion of healthcare spending for primary care. I know Washington is one of the states, along with Oregon and several others, who have worked really hard on passing legislation or issuing executive orders related to this recommendation. And we need to, and here's an area I think where those of us in academia can be super helpful, is we need to be evaluating those interventions and understanding what's working and what's not working related to how those initiatives are moving forward. So again, this really just summarizes the committee's recommendation for a complete phase out of peer fee-for-service payment in primary care. And again, getting back to what I was witnessing with COVID-19, we really saw the significant risk and the significant danger in a fee-for-service payment system when the services that need to be provided for the community are not billable. And there's a complete mismatch there. We saw a lot of primary care practices on the brink of closing. Some did close this year because of the struggles in keeping their doors open, providing services the community needed, and being unable to bill for those services or unable to bill adequately for what was needed. Moving into a hybrid model, there are some services that we should incentivize primary care to deliver because we can deliver them safely, effectively, and more cost effectively than other sectors within the healthcare system. So there is a recommendation for a hybrid model here. And then moving into risk-based contracts with the focus on population health, but again, ensuring that sufficient resources and incentives are moving towards primary care. One of the things I've seen happen is as systems save money, instead of reinvesting that money in primary care, the money moves away from primary care into other segments of the system. Second is access and ensuring that high quality primary care is available to every individual and family in our community. There were 5 action steps here. I'll just briefly run through those. The first one is related to universal empanelment. And this is having payers ask all beneficiaries to declare a usual source of primary care. And then that health centers, hospitals, and primary care practices should assume ongoing relationships for the uninsured patients they treat as well. And there may be people that choose not to utilize primary care, but everyone should have primary care accessible to them when and if they need it. The second step here is that Health and Human Services, the U.S. agency overseeing health, should create new health centers, rural health clinics, Indian health service facilities, and expand on many of the successful models for ensuring that disadvantaged populations, underserved populations have access to high quality primary care. Third here is that CMS should revise access standards for primary care for Medicaid beneficiaries and provide resources to state Medicaid agencies for these changes. This is really recommending that, again, the Centers for Medicare and Medicaid Services revise and enforce several of their access standards, ensuring adequate access to primary care, providing technical assistance to state Medicaid agencies for implementing and attaining these standards, as well as measuring and publishing how states are performing in this regard. The fourth action step, CMS should permanently support COVID-era rule revisions. We've noticed that there's more equitable access to primary care with telephone and virtual visits, providing equitable payments for non-in-person visits, and easing documentation requirements, expanding the role of interprofessional care team members, and eliminating other barriers. There's lots of heated debates going on about the disadvantages and the advantages of some of these COVID-era rule revisions. Again, another place where research is needed, really understanding these advantages and disadvantages and how to fully optimize these rule revisions in obtaining better access. And then the fifth action here, 2.5, was community co-creation and partnership building and adequate support for doing so. I think one of the main tenets along the way in everything that we did as a committee, and I think we really hit the mark on this. There may be a few places where it feels as if there are unfunded mandates put on primary care teams and local primary care systems, but we really wanted to say, hey, primary care practices should do this work to include community members in governance, design, and delivery, and partner with community-based organizations. And there needs to be a payment system and resource allocation to support them in doing so. The third objective related to the workforce is, again, many of these are pretty basic, and we've been talking about these for a long time. So I know you're saying, wow, I've heard this before. There is a lot of great evidence and new information that the committee was able to include in the chapters related to each of these recommendations. So I'm just giving really the high level snapshot, but the report's free online. Feel free to dive into any area that you're interested in. So this one, train primary care teams where people live and work. And again, this is not, let's just send all the students out to the existing primary care sites that are already overrun with patients and don't have the resources to teach those students and support those residents. It's working at the federal level and the state level to develop more policies and systems like our Teaching Health Center program and other programs that really enable the resources to move out into the community to support learners to train in the places where they will be practicing. So diversifying the workforce, customizing teams to meet the needs of the population, and incentivizing the different aspects within the educational system that really have been left behind in a number of the educational models that have been developed. And there's a number of examples related to things that can be done by the Health Resources and Services Administration, or HRSA, state and local governments, healthcare systems, redesigning and implementing economic incentives, loan forgiveness programs, salaries, supplements, et cetera. Organizing a data-driven approach to customizing interprofessional teams to meet the needs of the population they are serving. Not every population needs exactly the same team. And so really better understanding the team that is reflective of the population served and tailored to meet the needs of that population. Second recommendation, again, is getting into many of these programs that we know well and sustaining the programs, accelerating their impact, and enhancing the resources that go towards them. The fourth objective, again, as I mentioned, digital health was not in the 1996 report. Trying to think back to 1996 when I was a medical student and we were just coming online with the internet. I don't think any of the systems I rotated through had an electronic health record, or if they did, it looked nothing like the electronic health record we have today. I think we've obviously seen a huge explosion in information technology, the data that's available, the technologies that are available. So very new, rapidly expanding resources to serve our patients, families, and interprofessional care teams. Certainly an essential component, but with a lot of work that still needs to happen in order to support the delivery of high quality primary care. So a few actions here. The Office of the National Coordinator for Health Information Technology and CMS should develop next phase of digital health certification standards that support relationship-based, continuous and person-centered care, simplifying the user experience, ensuring equitable access and use, and holding vendors, especially those that sell high-priced EHRs, accountable. Alex Christ, who many of you know, was championing in this area and knows a lot more about this than I do, but certainly many of us understand electronic health records are developed for billing, not necessarily for supporting relationship-based, continuous and person-centered care. So lots of recommendations there and what can be done. And the second action step here was that ONC and CMS should adopt a comprehensive aggregate patient data system that's usable by any certified digital health tool for patients, families, clinicians, and care team members. And this is fundamentally different than meaningful use, which, while useful for promoting adoption and implementation of EHRs and patient portals fell short of what primary care needs today. This is asking for aligning with the functions of primary care. So supporting relationships, providing access and continuous contact over time, collecting and understanding the patient's story, having a person-patient family-centric focus rather than a current disease focus. Digital health systems need to automatically measure user experience. Primary care needs sense-making functionality and automated tools that make the right care at the right time easier to deliver. Really, again, holding vendors accountable and in partnership with state and national support agencies to be not the clinicians and health systems, but these other organizations holding accountable and financially responsible for achieving these benchmarks. And fifth, and we're getting to the end here, is this accountability and exactly how would that implementation recommendation be accomplished. So the first recommendation here, and this alludes to one of the things that our committee felt was missing from the 1996 report and certainly spotlighted in the COVID-19 pandemic, is that there is no agency that oversees primary care within the federal government, within most state governments, local governments, et cetera. So our recommendation is that HHS secretary should establish a secretary's council on primary care to coordinate policy, ensure adequate budgetary resources for such work, reporting to Congress and the public on progress. Again, being accountable to Congress and the public on progress, and hear guidance and recommendations from a primary care advisory committee that represents a broad range of key primary care stakeholders. This council could include such members as the director and administrator of CMS, the director of the Center for Medicare and Medicaid Innovation, or CMMI, from HRSA, from the Agency for Healthcare Research and Quality, the Assistant Secretary for Planning and Evaluation at HHS, and the National Coordinator for ONC. So a lot of high-level individuals who have siloed portfolios, but really bringing them together in an organized way to oversee and be held accountable for our primary care system in this country. There's a long list of things that the council would be coordinating. I won't read through many of those, but they're all in there. And this is, I think, one of the exciting recommendations that is beginning to move forward and getting a lot of play across the country right now amidst everything else that's going on. And then the last, or the other two recommendations here, is related to HHS forming an Office of Primary Care Research at NIH and prioritizing funding at ARC. So ARC has a Center for Primary Care Research that doesn't have a budget designated for that center. I believe this year there is a budget, thanks to the advocacy efforts of many family medicine organizations and others across primary care. And we also feel like, given that this is a large segment and component of our healthcare system, that NIH needs an Office of Primary Care Research to elevate the profile of primary care research at NIH. So it's not an either or, it's a both, given, again, the large role that primary care plays in our healthcare system. And then the last one is primary care professional societies, consumer groups, and philanthropy should assemble, regularly compile, and disseminate a high-quality primary care implementation scorecard to improve accountability and implementation. And again, this is not measuring the hundreds of metrics that primary care clinicians and teams are currently being held accountable for in many systems. This is a scorecard that our federal government and other public entities would be held accountable for delivering on. And so the scorecard would include measures that are already in use at this point, not new, although new measures are being developed and desperately need to be developed. There would be few in number that are easily understood and consistent. It would build on data that's regularly collected and publicly available. Certainly we could identify other data elements that we would like to regularly collect and have available, and it would be appropriate for use at a national and state level. So things such as assuring high quality primary care is available to every family and community. Let's look at the percentage of adults without a usual source of care. Let's make some progress on bringing that percentage down such that we have 0 people in our country that don't have a usual source of care. Let's then continue to measure other elements that are recommended here. So it's not looking at primary care individual teams and saying you're doing a poor job of managing your patient's hypertension. It's more at the system level and the government level of, hey, you know, we really need to hold ourselves accountable to these recommendations and if we're making progress in the right direction. And hot off the press today, and again, another thing that those of us in academic departments in centers across the country can be doing is amplifying some of the recommendations. So Kevin Grumbach, Tom Bodenheimer, Deb Cohen, Bob Phillips, Kurt Stange, and Jack Westfall, representing a group of a number of centers in primary care research and innovation, published today in the New England Journal of Medicine, so an amplification of the recommendation to create the Secretary's Council. There's been a number of other articles published based on the report, and certainly opportunities to continue publishing and highlighting different elements and aspects of the report. So another exciting way to get the word out there. And that's all I have. Again, I mentioned that you can download the report. You can get the entire PDF. Let me stop sharing my slides. These will be, certainly can be distributed. This is easy to find, National Academies Primary Care. There's also an email related. There's, I think, a few resources being developed, but certainly another place where I think those of us in academia can help is translating some of these recommendations at different levels. So some people are really great at talking about the science at a high level, but others are really great at putting together one-page policy briefs to help our policymakers and our payers and our healthcare system leaders understand what the recommendation is in a bite-sized bit of information. So this is the actual book that you do have to pay for if you want to, but you can download the PDF for free. And there's, again, other resources, including a number of webinars that were recorded in June, highlighting different chapters in the report. So thank you again. Hugely grateful to this committee. I think over the last couple of years, if not, as I said, 7 years since I think it's been since we really started pushing on getting this report launched and completed. But so much so in this last couple of years, I think an overused cliche is that we are running a marathon, not a sprint. We've actually moved beyond that to say we're running a sprint relay race, and many of us are sprinting as fast as we can and then handing the baton off to someone else. It now feels like a sprint marathon relay race. But I was super grateful in the beginning to be involved in getting the committee launched. I really did pass the baton on to a number of these committee members who did the heavy lifting over the last 1.5 years, because I've been living, breathing, sleeping, eating COVID and all the work that's happened there. So I don't have a lot of the detailed answers to some of the questions, but can certainly put you in touch with people that were doing heavy lifting on writing this report over the last 1.5 years.
Well, fantastic, Dr. DeVoe. Thank you so much for your talk. I imagine there's quite a bit of questions and discussion to be had, and I want to turn it over to the audience at large, and first, before I selfishly ask a couple questions myself. But I want to ask if any questions for Dr. DeVoe or discussion points, please unmute yourself and please jump in. I'm going to start the conversation then. So I kind of think of lectures like this in terms of like when I was a resident and now when I'm involved in resident education. And I guess I'd just ask you, when you have, some of the energy of our residents in our department is kind of unbelievable. It makes me think how I was fortunate enough to be a resident here, considering who I am working with here. And what would you have me, what would you advise like new residents with their big dreams and aspirations, like how to get involved in some of the changes that this committee has recommended and that sort of thing?
I think we have the great advantage both in Washington and Oregon of being in a state where policymakers are enlightened and understand some of these recommendations. So again, as I said, there may be some translational steps that need to help those policymakers understand these recommendations and implement some of them. So I certainly think there's a role for residents to dig into policy recommendations around payment, around state policies to increase spend on primary care. If people are really interested in research, hooking them up with, health services researchers or health policy researchers that are, diving into trying to study some of the interventions that are happening either at the state or the national level. So there's a lot here. Each chapter in itself could probably be, a year-long or 10-year-long course for residents and medical students. So it might be kind of figuring out, are they really interested in community-oriented primary care? Go to the community chapter. Are they really interested in payment? Go to the payment chapter. Are they really interested in IT? I kind of had to read the part that Alex had written about IT because despite the fact that I've worked with a lot of data over the years, I'm not as versed in informatics and what some of the next steps are in order to improve our IT tools. So I think there's great, especially with the generation that understands some of those tools better than I do, I think there's great opportunities for partnering up our students and residents with IT and informatics folks and kind of helping to bridge that gap. I noticed that, a lot of these tools are developed by folks who know IT really well, but don't understand the healthcare setting at all. And so that's another really great place for translators of, having users and folks in the midst, whether they're patients or clinicians on the team, really sitting down with IT folks and doing more user-centered design and user influence on improving on the tools as well. I know it's hard in big systems to change your EHR, I get it. But there are, I think, sometimes our informatics folks listen more to our residents than they do some of us with more gray hair.
Hi, Jen. This is Carrie Stevens. I'm sorry, I'm away on vacation a little bit, but a little noise in the background. But speaking of IT, and I know, we crossed paths back in Pcornet, a while back as well. And I thought I'd just follow up and ask, here at UW, we are launching a new EPIC team to actually be able to support research, which is crazy that we haven't had that up until now. And I'm just wondering if you've got thoughts, either specific ones or people that you'd want to point our direction as we think about informatics in primary care, of what you think some priorities are, maybe things that came up in the conversations you guys were building this report that you feel like are, huge pain points for primary care that we could be doing in terms of sharing the data in practice and really working on this learning healthcare system.
Yeah, that's wonderful. Good to see you again, Carrie. I see lots of familiar names on here and familiar faces. So thanks for being here on a gorgeous evening in the late summer. It's hard to even pick a few. I think there's a lot of energy. And again, to your point, Dave, there's a lot of energy around social determinants of health, but we really are just scraping the surface on should we be asking patients all these questions and what are we going to do with all this data and how can the tools be built in a way that they're useful to the teams? So I think that's a big area for further exploration. I don't know that the evidence is caught up with everything that's happening. So if your system's focused at all in that area, I think primary care should be driving it. What do your teams feel is going to be most important? So get ahead of it so that tools aren't built that really burden the teams and burden the patients, but with no impact on population health outcomes. So that's kind of a big area, but I think one that is exploding. And then, we're all sort of stuck with EPIC, most of us. I'm presuming you have EPIC. So it's really getting to know your physician builders or your IT builders and getting your needs prioritized in the large scheme of things as far as what could be built, what needs to be built. Luckily, there is room for customization and tailoring the system. It's more just getting into this prioritized scheme of things where, at least in our system, inpatient needs oftentimes get prioritized ahead of outpatient and certainly primary care. So some of it may be political and advocacy, getting in those prioritized conversations, making sure you have people in the conversations and that you know what your teams need. I feel like there is also room for partnerships with big payers. So if your big payers are willing to be good partners and creative partners and pay in alternative ways, but certainly want some information to hold you and your system accountable for delivering high quality care, there might be some interesting partnerships there. Again, not knowing your payer landscape, but we have the opportunity here to be essentially like a accountable care organization for a population of our Medicaid patients. And I think that's helped move some of these ideas further to the forefront because we're now at full risk for that population. So getting our teams information about how do we support integrated behavioral health? How do we, again, identify and address social determinants of health in a meaningful way? How do we share communications, enable e-consults and other things to flow so that we can get access to the specialty care needs that some of our most disadvantaged patients have and have traditionally not gotten access to, that sort of thing. Again, back to the basics of all these things that we've really wanted to do over the years. But those are at least some ideas off the top of my head. But I think there's a lot in this chapter. Again, Alex Christ is one of my heroes. He's been a family physician, public health informaticist, developed the interactive My Preventive Care personal health record when he recognized that most of the patient portals that exist right now are very static and two-dimensional. He developed an interactive one so that patients can go in and better tailor information to their risks, and has done a gazillion other things in this area. So it's a great chapter. And Alex's, there's webinars again on all these topics on the website. And I know he was front and center on the one about digital health. So there's probably some great ideas in there as well.
Thank you.
Jen, hi, this is Paul. Thank you so much for sharing this report with us. Question, perhaps it's about advocacy or the allies that we need to create to implement a high functioning primary care system. And my question actually relates to, you mentioned how primary care helps alleviate some of the injustices of our current healthcare system. And I guess it's not lost on the committee that we do live in a society and in a healthcare environment where there is systemic challenges for certain populations to get adequate healthcare. And you mentioned the advocacy work at the federal government. John Guyman, one of the past chairs here, is just a real vocal proponent that we're not going to resolve our problems until we can identify, for example, a single payer system. I assumed that was considered too heavy a lift, or that the politics are not there. I'm wondering about what the scientists think about how we get to this high functioning system, and what advice might you give us in terms of advocacy?
Yeah, I think there's heated debate. I think the statement of task and the scope of the work for this particular committee was not to kind of hash out single payer versus multiple payers. And it was to say, let's assume our system is going to exist as it does with all of its dysfunction and all of its imperfections. What can we do to implement a high functioning primary care system within that context? And I agree with you, maybe that's not possible because there are these systemic issues both within the healthcare system as well as far outside the healthcare system that impact our patients' ability to optimally be healthy and live healthy lives. So there was a lot of really kind of debate and conversation about that. Certainly there's evidence, and there's a number of other Academy reports that do focus more squarely on what you're describing. And so we kind of felt like that ground had been covered by a number of other reports. And so some of those reports are referenced in various places saying this report really addresses that issue. We were told to kind of assume we're operating within the current context. And I saw a chat come in. Let's see here. Primary care spend is a straightforward message with similar intended outcomes. Yeah, so I think that's kind of where we landed, was assuming that we're in a multi-payer system and it's very complex. One of the recommendations, and again, there's still not a lot of evidence, but emerging evidence that advocating for primary care spend and then holding our systems accountable for actually spending on primary care, that amount. But, you know, there's still a lot of scientists trying to figure out, well, what is actually primary care? We have the definition, right? But is it services provided? Is it providers that are designated as primary care? And when you look internationally, different countries measure it in different ways based on what data they have available. So we can ask our states to spend 12% on primary care, but then what's included in the denominator, what's included in the numerator? You know, we had the frustrating experience here in Oregon where we passed legislation for 12% spend. And what we had seen in the data at the time was that we were spending somewhere between, you know, 5 and 6% across all payers, some more, some less. And then an analysis was done in the same data set that showed, oh, lo and behold, we're spending 12%. Well, how did that happen? Well, people just removed a lot from the denominator, right? So they all of a sudden were able to sort of miraculously achieve this. So there's loopholes. And I think that's where I think, again, researchers and academics can say, wait a minute here, you know, there's the intent of this. And then, you know, there's the shortcut way to get here, which is just fudging the numbers. And then there's the actual meaningful way to get here, which is spending it and figuring out where it's going and whatnot. So even the primary care spend isn't the panacea. And I'm sorry to relay that unfortunate experience in Oregon. We tried to close the loophole with another legislative session and the payers really were able to block it. So still working on it because there was a loophole and it was essentially understanding what should be included in the denominator. So if you take a lot of costs out of the denominator, then you get to a higher spend with the exact same numerator.
Right.
And then again, so all this work is going on simultaneously. Once we, I think, have a better sense of like, yes, this is primary care, no, this really isn't, then we'll be able to monitor and track it. And if we had a federal agency or organization that was holding states accountable, and then I think at the state level, and maybe those of us in states that understand primary care better, and again, are more enlightened and willing to try out some new and innovative approaches, maybe we need a secretary at the state level as well. Some states have surgeon generals now, maybe it's in the surgeon general's office, maybe it's in your health authority or whatever is your equivalent of HHS at the state, and advocating for somebody there that's keeping a closer eye on this. It also gets away from professional organizations doing it because professional organizations get seen as self-interested and wanting to pad our pockets. But if it's really the public and the patients and the community saying we demand that we have a higher quality and more equitable and accessible services here, and we're going to hold the state accountable for it and hold payers in the state accountable for it in systems.
On the question,
go ahead.
I'm sorry.
Go ahead, Dr. James, please. Go ahead.
Well, and I don't want to monopolize. On your thinking about primary care, and Oregon is a state like Washington, Jen, where you have a significant rural workforce of family physicians that actually still do the old family medicine in a futuristic way. When you're thinking about spend and those doctors where they're doing, for example, OB, they're doing inpatient work. And I think as opposed to an urban model where there's a tendency, especially by the insurers, to see some of that work that rural family doctors do as hospitalist work or laborist work. Do you have a way of thinking about the different environments that we practice in and whether there should be differences in how we think about the primary care spend?
Well, you know, here's where having, you know, shoring up our primary care research infrastructure, because all of these are hypotheses that haven't ever been tested. I know there's been some work to test the hypothesis that, you know, having a primary care team, whether it's a physician or someone on the team involved in the hospital setting with a patient they've known for 20 years, making end-of-life decisions or making critical decisions is important, not only to be patient-centered and have the best outcome for that patient, but is also maybe going to save the system money. Not that you're there to gatekeep and say, oh, don't do all these things, but sometimes patients don't want all these things. I mean, that was the experience with my father, as I was the voice to say, I've known this person my whole life and he doesn't want all this. And I could explain to him what the informed consent conversation, how that really needed to go because he trusted me and knew me. So there's a lot of things, even in urban settings, where maybe you don't have the primary care physician serving in the hospitalist role and managing the patient in the ICU, but you're in a consult role in the same way that they're consulting cardiology or even palliative care. Palliative care consults are fabulous, but it's often someone walking in the room meeting a patient for the first time that I've known for 20 years. There's not an easy way, even in our current system. I just go over and do it because I have the luxury of administrative time and having my office right across. I'm in my office now, which is across from the hospital where my patients get admitted. You know, I think in residency programs, we get to hold on to that a little bit as well because we're required to do that inpatient work. But I think, you know, there's a lot of the recent studies showing that comprehensive scope of practice keeps people well in the workforce. It does save money ultimately. Continuity of practice similarly. So some of what our system has moved towards, we need to start questioning those movements and testing hypotheses that where we are, whether it is an urban or a rural setting, is the best way to deliver care. But you know, you hear about some of this happening. Jack Westfall talks about Colorado and some of the payers being willing to pay for primary care physicians to round on their patients in the hospital and feeling like that was the right thing to do, but nobody really studied it to the point where I see it published anywhere. So it's hard to bring that forward. Other systems have looked at, Kaiser Permanente in our region years ago looked at continuity of care and different people on the team and really felt like it was important to have, you know, primary care physicians and physicians that had continuity panels and, you know, but a lot of that stuff was done and not ever studied, or the studies were not published. So, and we know why, because there's very limited resources to do those kinds of studies right now. So again, that's why we thought research was going to be woven throughout the report and then ultimately realized it needed a separate chapter. So there is a separate chapter focused on research, which I think will be helpful in advocacy efforts around what needs to happen at ARC and NIH and other places to fund more of the kinds of, you know, type of work you're talking about. It may be that payers end up funding that work. I don't know. You know, again, they're partners in this effort. I think certainly they're focused on those short-term cost savings, but some of the payers are more focused on longer-term initiatives and a broader quadruple aim. Especially the public payers, I think, and maybe some of the private ones as well.
Okay. Awesome. Thanks again. Thanks, Dr. DeVoe. If there's maybe time for maybe one more question, I know we're coming up on time here, but I think this was a really important conversation. So
mine is just a wrap-up question. So I said,
I
think the main takeaways that I heard for individuals would be amplify the recommendations, advocate where you can for the recommendations, especially the ones that require some sort of government or regulatory agency action. I added, put your qualified colleagues forward when positions come open, like on the Secretary's Council, because I think it tends to be the same people that get circulated in the national conversations, and it's really nice when other names come forward. Anything else?
Yeah, and I honestly think a lot of this work is happening. Again, it feels like we're moving slow in Washington and Oregon, but when you look across the country and you talk to people from Mississippi or Oklahoma, they're like, oh my gosh, you're so far ahead. So one of the main purposes of this report is that you can now say the work you've been doing for 5 years, the National Academies recommended this. And it does hold to, you know, it. Sometimes people don't listen to me, but if there's a National Academy report that recommends it, maybe they'll listen to that. So use it to continue your work as well, I think, wherever you're at. And then again, as I mentioned, I think it is a great educational resource. It probably should be a required textbook for all residents, but who has time to read, right? But there is just, you know, the fact that there was over 6,000 studies and pieces of literature reviewed in here and much of it cited there, I think it's really gratifying to see how far we've come even since 1996 in having the evidence base. We've all drank the Kool-Aid, but now we have a more robust evidence base and it's all in one place to continue moving forward. So use it, for academic purposes, use it for advocacy purposes. Again, a lot of people on the committee that you can reach out to who would be super helpful in, testifying before your legislature or other governing bodies or places that you're, trying to move the needle. Keep an eye out too for, like any of us have time to write grants right now, but, a lot of these recommendations and I think additional resources coming available are going to be, HRSA is going to be having calls for expanding teaching health centers, rural. You guys have a huge rural emphasis, and so a lot of the federal initiatives that were spurred on by these recommendations are going to start popping out. So keep an eye out for them and pull teams together to apply for funding to keep moving things forward too.
Well, excellent. Thanks so much again, Dr. DeVoe. We really appreciate it. If I can just briefly speak on behalf of our department, we really appreciate your time and expertise in starting this conversation with us. It's really quite a lot to think about, that's for sure. I'm going to kind of wrap it up there. Thank you for coming, everybody. We'll see you next month for Dr. Domino on September 15th. Have a fantastic evening, everyone.
Thanks for having me. Keep up the great work, all.